Hello, I'm John O'Brien, and through the NIHR-funded Diamond Lewy programme, we set out to improve the diagnosis and management of Lewy body dementia. By Lewy body dementia, we're including both dementia with Lewy bodies and the dementia that develops during Parkinson's disease. Now, we know that Lewy body dementia is a common cause of dementia, responsible for around 1 in 10 cases, but the cases are often missed or diagnoses made late. In an accompanying video, we talk more about Lewy body dementia and the reasons that it is difficult to diagnose. In the other video, we introduce assessment toolkits for the diagnosis of both dementia with Lewy bodies and Parkinson's disease dementia. And if you haven't seen our other video, we would recommend that you do watch that. However, diagnosis is not an end in itself, it's just the beginning. Diagnosis is important, and people with dementia and their families often find that it provides a start or a doorway to accessing better care, better services, and better support. But the other important thing about diagnosis is that it allows specific management of the subtype of dementia, in this case, Lewy body dementia. And this is why we developed, through the Diamond Lewy programme, a specific management toolkit to support the management of Lewy body dementia once it's been diagnosed. Now, there are particular management challenges around Lewy body dementia, which are different from those from other dementias. Lewy body dementia is associated with multiple symptoms: cognitive, motor, neuropsychiatric, and physical. Treatments for one symptom can make another symptom worse. Fluctuations, which are a core part of Lewy body dementia, may make the assessment of response difficult in a clinical setting. It can be challenging to identify the most troublesome symptom for the person with dementia and their families. But most of all, there's a lack of a systematic approach to management. To fill this gap, we developed the management toolkit, and we developed this in 3 parts. Firstly, we undertook evidence-based reviews, including reviews of our own of pharmacological and non-pharmacological management. We used these as a basis to develop some management statements, which we then put through a Delphi process where we asked 25 experts from different countries whether they should be part of the management of Lewy body dementia. Then we piloted a management toolkit in clinical services in the UK to make sure it was fit for practice, running in busy clinics. The toolkit is structured in 3 parts. There's an overview sheet of the main symptom domains that need to be considered in Lewy body dementia. These are cognitive symptoms, neuropsychiatric symptoms, motor features, autonomic symptoms, and sleep disturbances. Underneath this, there are 5 individual summary sheets which go into more detail about each symptom domain. Finally, there's a guideline which is referenced and includes further information on how the toolkit was developed. When using the guideline, it's important to focus on the key problems that the person with dementia and their family describes at the time. Often someone will have many symptoms, many problems, and it won't be possible to manage everything at the same time. Indeed, it's rarely the right thing to do that. So creating a problem list and identifying the most important problem is key. Now we're going to see use of the toolkit in action with some clinical vignettes and examples of management approaches that are taken from the toolkit. You may well find it helpful to have the toolkit in front of you as you watch these. The toolkit can be easily downloaded from the Diamond Lewy website as shown on the screen, or simply type Diamond Lewy into your favourite search engine.
Okay, Margaret, so last time we met, you told me you're having some good and bad days, but then most of the time, you're
Yes.
pretty much managing independently. So just tell me how you are at the minute.
Pretty much the same. I'm still having problems. It comes and goes. Yeah, I don't know why, but it just does.
Okay, you having any particular difficulties with things that previously you managed okay with?
More sort of technical things. I'm struggling with the TV remote. I can switch the TV on. I just switch it on, and then my mind just goes blank as to how I do anything else. You know, how I change channels or.
She can be there quite a while.
Okay,
Yeah,
okay.
yeah, and it's difficult and upsetting. Yeah.
How's because I know you've got a mobile phone. How do you manage with that?
Similar sort of thing, really. I can if I get a text, say, I know how to look at it, but I cannot remember how to deal with it after that.
No, she does really struggle with the texts. And sometimes you've even sent them to different people
yeah,
who have been
and consequently,
texting.
well, really just ignoring it, really.
But can I just clarify, is that consistently all the time, or sometimes do you manage these tasks
Sometimes
with
I
ease?
do, yes, and I don't know why, if you know what I mean. I don't know why I can one day and then struggle again another day.
Okay, okay. And you know, how long has this been going on for, would you say?
I don't know. I can't really remember. What do you think? Weeks,
Okay.
more than
Yeah,
that.
yeah, I would say so.
And
yeah.
how much of a problem is it for you, do you think?
Well, if my husband's around, it's okay. I mean, I suppose it's not a real problem.
It's more of a frustration,
It's
I think.
frustrating and
Yeah.
I feel stupid.
Okay. Yeah, it's difficult, isn't it? Okay. So Valerie, have you noticed anything?
Yeah, I mean, I've noticed things like sometimes Mum can look at me a bit vacant, like she's looking right through me. Sorry, Mum.
Yes, it's okay.
Don't like talking about it. And sometimes, you know, when you ask a question and the response sometimes doesn't make sense. She doesn't always make sense. And the way her speech, yeah, I can't always understand as well. Sorry.
But again, can I just clarify, this is not all the time, it's only some of the time.
Yeah, it is, yeah.
And then other times your mum is how she's always been.
Yeah, absolutely,
Okay.
yeah.
So can I ask, Margaret, how did you get on with the cognitive stimulation therapy?
I really enjoy it.
It's fun, isn't it?
It is fun. They ask you to make up a team name for the group, and sometimes there's songs, and they're a nice group of people, and the staff are really nice as well. I look forward to it.
Great.
And Dad says, doesn't he? He says when you come back, he
Yeah.
mentions that you're always a bit perkier. She always seems
Okay,
quite happy,
good.
quite positive.
Yeah,
And the staff have mentioned before, haven't they, that you participate well with them.
yeah, they have.
Yeah.
Yeah.
So it sounds like you've really benefited from these non-pharmacological treatments, having the structure, the stimulation therapy itself, but also that routine to your day. And if you could build that into your general day-to-day activity, then that will be helpful for you.
Okay.
But now it might be time to consider some other, maybe pharmacological options, I think.
Okay.
Cognitive symptoms are a central feature of Lewy body dementia. These are typically global, although often people with Lewy body dementia can experience disproportionate impacts in terms of attention and executive function, as well as visuoperceptual and visuospatial function. In addition, people with Lewy body dementia can experience marked variations in cognitive performance, so-called cognitive fluctuations, and this is a core diagnostic feature for dementia with Lewy bodies. Within the toolkit, we have a one-page summary detailing best approaches to the management of cognitive symptoms, and this should be consulted in conjunction with the current video. Let us look at the key points from the management guidelines in regard to cognitive symptoms. Firstly, it is important to establish the presence of significant cognitive difficulties which warrant treatment. Remember, of course, impairments in cognition can fluctuate in Lewy body dementia and may relate to memory, attention, executive functioning, visuoperceptual abilities, as well as disorganized speech and communication. Evidence for any cognitive difficulties can be obtained from reports by the patient and an informed carer, and also from the results of objective formal cognitive testing. Remember that cognitive fluctuations, whilst intrinsic to Lewy body dementia, can also be a feature of delirium. Therefore, exclusion of delirium is important. Also consider what other factors might be causing or aggravating any cognitive decline and exclude these. As we have heard, non-pharmacological approaches to managing cognitive impairments in Lewy body dementia may be helpful. These may include cognitive stimulation, use of memory aids, increased social interaction and stimulation, as well as exercise. Looking at pharmacological management of cognitive symptoms, first line, consider the use of cholinesterase inhibitors. The choice of cholinesterase inhibitor is up to the clinician, but systematic reviews indicate that donepezil and rivastigmine are similarly effective in both dementia with Lewy bodies and Parkinson's disease dementia. Galantamine may also have positive effects on cognition as well as neuropsychiatric symptoms, but due to the fact that the data is limited for this agent, recommendations are more based on donepezil and rivastigmine. From our expert Delphi panel, rivastigmine patch was also considered an option, particularly if there were swallowing difficulties, compliance issues, or a history of significant response variation to oral dosing. At present, data are limited and inconsistent for the use of memantine. Our guidelines suggest using it as a monotherapy if the cholinesterase inhibitors are not tolerated, or if there are any other contraindications to the use of these agents. One might consider the use of memantine in combination with cholinesterase inhibitors, particularly if the effectiveness of the cholinesterase inhibitor is limited or declining, or indeed the disease is becoming more severe.
So Valerie, while your mum's away having her blood pressure checked, can I just ask you about these hallucinations that she's been having? Tell me about them.
Well, I know she's started to see our dead dog, Cassie. She passed away, be about 15 years ago now, and she says that she can see her in front of the fire sometimes of an evening, but I know she's mentioned it sort of during the day.
Okay, anything else?
The insects. She sees these insects just going along the skirting board, and she does keep commenting on them. Me and Dad just keep saying that, there's nothing there.
And how often is this happening?
I'd say daily now.
All right.
Yeah.
Okay. And how much of it is a problem for your mum? How distressed, for example, does she get with these things?
I wouldn't say at all, to be honest.
All right.
I don't think she is distressed. I think she just deals with it. She just sees them. She tells us she's seen them, and then leaves the room to go into the kitchen, and she gets a little duster, and she can often be seen just flicking along the skirting boards, trying to get rid of these insects.
So she actually tries to interact with them.
Yes.
To remove the insects.
Yes.
And the dog, does she?
Oh yes, yes. She leans forward, trying to stroke it.
Okay.
Yeah, Dad's often said that she's done that.
Okay, so quite clear there probably are hallucinations as opposed to memories or false beliefs that she might have.
Oh no, I think she sees them.
Yeah. Okay. Has she had any investigations recently to, ensure that this is not due to, say, an infection or any other problem?
Well, it's over the last sort of couple of weeks we've been noticing it more.
Okay.
We did take her down to see Dr. Sayer because he was, it was my dad really who said we'd pop her in and just see if she's got an infection or something. But he said that she was fine.
Okay, so they've been going on for a few weeks, maybe slightly worse more recently, is that what you mean?
Yes, I would say so.
Okay, but the tests were negative?
Yeah.
Okay, good, okay. It sounds like these are not too troubling for your mum. Has anything else happened that she has been distressed about at all?
There was the cushions. Mum and Dad have these sort of like scatter cushions just sort of thrown over the sofas.
Okay.
And it was Dad that mentioned it first, that she'd said that she could see people, she could see faces in them.
Right.
And it happened a couple more times. So, I mean, we just took the scatter cushions off, really.
So that helped?
Yeah, it seemed to. We just put them in the spare bedroom.
That's a really good strategy, actually, to remove things that can trigger either misidentification or illusions or hallucinations. And the other thing that I think you can try is having very plain soft furnishings, you know, things without big patterns on, because again, sometimes that can create a problem and misidentification.
Oh, right, okay.
Mirrors as well can be an issue if there's a difficulty with recognising a reflection.
Oh, right, okay.
So there's some of the things that you could consider for the future if that becomes an issue.
Yeah, there are quite a few mirrors around Mum's house.
Has your Dad mentioned anything else? Anything that she's been upset about? Any unusual beliefs that she might have had that might be worrying her?
There's the Mum started accusing him of spending her money, and he's not. I mean, he's not that kind of person, and he keeps on telling her, but I know he's getting upset by that.
Sure.
He's quite distressed by that because it's well, he just feels like he's under suspicion all the time, and sometimes he can't reassure her, and then sometimes he can.
And is this similarly a daily occurrence, or
maybe sort of through the week? I don't know if it's every single day.
Okay.
He doesn't mention it every day, but I think for me that's probably how upsetting he's finding it. But I know that she has been doing that.
do you have any idea whether it's causing any significant conflict at home? Arguments, aggression, that sort of thing?
No, I wouldn't say so. Not when I talk to Dad and
Good. That's
talk
good.
to Mum. No, I wouldn't say that there's any problem like that.
Okay. And if you try and give her some reassurance if she's having the hallucinations or talking about her money, for example, how does she tend to respond to that?
Not too bad, actually.
Okay,
yeah,
good.
I can seem to just reassure her gently. She seems to be okay with it. Yeah.
Okay. Oh, that's I think that's reassuring, really. Good.
We have heard about visual hallucinations, and these are one of the commonest neuropsychiatric symptoms in Lewy body dementia. Neuropsychiatric symptoms have significant impacts on quality of life both for the person living with Lewy body dementia as well as their family and caregivers. We have a one-page summary sheet for the management of neuropsychiatric symptoms and advise looking at this in conjunction with this video. Today we will focus on visual hallucinations primarily, but be aware there is a wide range of other neuropsychiatric symptoms including delusions, apathy, depression, anxiety, as well as agitation and aggression, and hallucinations in other modalities. There are a number of general principles with regard to the assessment of neuropsychiatric symptoms. Firstly, establish the presence, severity, and impact of any significant neuropsychiatric symptoms and those which warrant treatment. It is also important to consider obtaining a collateral history for symptoms. Systematic rating scales may be helpful in certain cases. Also consider what other factors might be causing or aggravating neuropsychiatric symptoms, such as mood disturbances or behavioral disturbances. Things such as physical illness, pain, discomfort, or environmental precipitants need to be considered. Clinical trials in Lewy body dementia have tended to aggregate neuropsychiatric symptoms together or used composite outcome scores. When considering these, several pharmacological agents have demonstrable efficacy. As part of our guidelines, we recommend first line the use of donepezil or rivastigmine. Galantamine may also be considered, although data are less robust. Second line treatment options include memantine and antipsychotics. In the following slides, we will look at treatment of visual hallucinations as an exemplar. Looking at visual hallucinations, it's first of all important to consider that not all visual hallucinations may need treatment. Indeed, some hallucinations may be regarded neutrally by the patient or even sometimes comforting or pleasurable. Simple explanations of the visual symptoms as a consequence of impaired visual processing may help allay fears and avoid the need for medication. Interventions such as removing cushions, patterned curtains, or other stimuli that might be precipitating visual misinterpretations, illusions, or hallucinations can sometimes be helpful, as well as the provision of good lighting. From a pharmacological perspective, cholinesterase inhibitors are first line for the treatment of visual hallucinations and Lewy body dementia. If these are ineffective, then a trial of an antipsychotic may be considered. If antipsychotics are used in Lewy body dementia, be aware that there is no clear trial evidence regarding their efficacy. Clozapine, which has been shown to be effective in Parkinson's disease psychosis, might be helpful in Lewy body dementia, although the evidence is lacking. There is no evidence to favor any individual one antipsychotic in Lewy body dementia, although atypicals and low potency agents such as quetiapine appear to have the least side effects. Newer agents such as pimavaricin may be of benefit with a better side effect profile, although this drug is still not available yet in the UK. When prescribing antipsychotics in Lewy body dementia, it is important to have a full discussion with the person with the Lewy body dementia and also family members and caregivers about the possible benefits and risks of the treatment. This should be recorded in the medical notes. It is important to identify target symptoms and monitor these regularly. Watch out for severe antipsychotic sensitivity reactions, worsening of cognition, or more subtle deteriorations in motor function. Always consider using the lowest possible dose. Make sure that the use of the medication is time limited and regularly reviewed.
So Bill, tell me how you've been feeling in your spirits recently.
Bit up and down, I suppose.
Mm-hmm.
Yeah, sometimes not too bad, and other times just feel a bit low.
Mm-hmm. Any tearfulness?
Yeah,
Sometimes. Okay. And can I just check sort of other symptoms like your appetite?
The appetite's all right.
Okay. And your sleep?
Yeah, I sleep quite well.
Mm-hmm. Yeah.
Good. Have you noticed anything at all in terms of your dad's mood? Anything that made it better or makes it worse?
I would agree with what he says. He's quite up and down at times. But I have noticed that you do get quite anxious if we've got anything, if he's got anything that's out of the normal routine.
So change of a routine.
That would make you quite up high, wouldn't it, Dad?
Mm-hmm. So when you went to the day hospital, was that something that made you more anxious in the morning beforehand?
Yeah, I was very anxious to begin with.
Okay.
But yeah, when I get there, I quite like it.
Okay, good. And when you come home, how's your dad seemed when he's been away for the day?
I would say that yes. I think the anxiety is about it being something different, but when he gets home, it really has sort of helped to have conversation with other people. You know, it really seems to bring you out a bit, doesn't it? You feel more stimulated, so to speak.
Mm-hmm. Well, that sort of social activity and maybe structure really does help and have a positive impact on the mood often. I did wonder how you'd got on with that rivastigmine medication that you tried for your memory, whether or not you'd had any side effects, for example.
I think maybe I have to go for a pee more often, but I don't know if that's because of
Okay.
that.
Okay. Yep. It could be due to that. Any benefits that you'd noticed, particular, either of you?
Yeah, I think so.
I think so. Yes, I think certainly gained sort of able to focus on things a bit better.
Okay.
You know, you've been a bit more alert, haven't you? So
Yeah.
I think.
I've been following the cricket more on TV.
Yeah, cricket.
And for a long time I wasn't that interested.
Okay, so not just the alertness that it had improved, but you were actually a bit more interested in doing things once you were established on the treatment.
Yeah.
Okay. Well, I think, to reinforce the benefit of that sort of structure and social activity would be something that we should continue and try to incorporate in your day-to-day routine.
Mm-hmm.
Yeah.
Okay.
Good.
We will touch briefly on the management of neuropsychiatric symptoms, including anxiety, depression, and apathy. There is no clear evidence base for the management of apathy, depression, or anxiety in Lewy body dementia. However, our expert panel made a number of recommendations. In regard to apathy, environmental stimulation may help reduce this, and it may also improve with a cholinesterase inhibitor. There is no evidence at present to support the use of psychostimulants. In regard to depression and anxiety, consider the use of social interventions. Pharmacologically, consider the use of SSRIs or SNRIs, but avoid antidepressants which have significant anticholinergic effects, such as tricyclics. Cholinesterase inhibitors may also help some, particularly if there is an associated apathy component.
Hi, Bill. How are you finding your sleep pattern at the moment at night?
Night I sleep quite well, I think.
Yep, good. And during the daytime, do you tend to drop off to sleep at all?
Yes, I do. I mean, even if I've just got up, sometimes I can sit down and I just nod off straight away.
Okay. Can you be asleep for some time?
Yeah. Couple of hours maybe.
A couple of hours, all right,
Sometimes.
okay.
Sometimes even longer.
This is not causing you to miss any meals or interfere with the rest of your day-to-day activity, is it?
No, I don't think so.
Okay.
It does tend to nod off a lot, and it does worry me a bit because it seems that the minute you sit down, you seem to be able to fall asleep. You know?
Yeah.
So that it does concern me a bit.
Yeah.
Particularly as you sleep okay at night. That's the main thing.
Yeah. So how often is this happening for you?
Oh, I can fall asleep, 2 or 3 times a day, maybe more.
Well, I come round every day now, and when I come back from work, I always find my dad asleep in the chair, so I think you're probably right, it probably could be more than that.
Okay. When you're round, for example, and you're able to have a talk to your dad, you maybe watch television together, is he able to remain awake?
Oh yeah.
Yeah?
When we're talking, everything's absolutely fine. And even sort of at the weekends when the whole family go around, I mean, when you're talking to the kids, it's as if there's not a problem. When we're talking, it's never likely to sort of fall asleep during that.
So if there's plenty of stimulation around, you're able to hold your attention and stay awake. Do you feel like you want to drop off to sleep, in that sort of situation when your family's here?
No, not if the family's
No. Okay. So usually when you're by yourself and there's not much going on.
Yes.
Yeah. Okay. So what we would usually recommend is to try and reinforce building in that structure to your day when you've got plenty of things to do. And you could include something like going for a very short walk. If you can't manage to get out, if the weather's not so good, just do something active around the house. So have that structure throughout the day, and that does tend to help keep awake. Could I just go back to say what you said, Jeff, about being worried about this? Sometimes we do need to exclude other treatable conditions that might cause people to sleep excessively throughout the daytime.
Right.
It is a recognised symptom, of Parkinson's disease dementia, Lewy body dementias. But there are other treatable conditions like sleep apnea. So have you heard your dad snoring loudly when he's been asleep? Or, sort of becoming sort of startled and waking himself up as if he hasn't got his breath?
I don't think so. No, I've not noticed that.
You haven't?
I don't know if
Okay.
you've noticed anything.
No, I don't
Okay.
think so.
Okay. I think going back to reinforcing the sort of daytime stimulation, I think that would be something useful to continue to do. But the other thing we might consider is increasing that rivastigmine medication that we started earlier, because that can sometimes help sustain attention and keep you awake throughout the day. So how's your sleep at night time been, Margaret?
Better. I am sleeping better.
Yep, good.
I've been told that I appear to be getting a better night's sleep, so yes, I feel better for it.
Have you done anything that has contributed to that improvement?
I took the advice, and I don't drink coffee now. I still have to get up to the loo, but I tend to sleep through now, which is quite good.
Yeah.
And also I have been taking some exercise, going out when I might in the past have actually nodded off, so I go for a walk.
Brilliant, yes, that's a really good strategy.
Yeah, and I feel more tired and ready for bed.
Yeah. So during the day, are you feeling any less tired now?
Yes, I think I am. I didn't always understand or know what was going on, but that seems to have changed, and consequently I'm getting a better night's sleep. Yeah.
Okay. So Valerie, has your father mentioned anything about your mum's nighttime sleep behaviours?
Well, Dad he moved out, didn't he, Mum? He moved out of the room. He sleeps in the spare
was
room.
disturbing him at night and thrashing around, and had
Okay.
thumped him a couple of times, I believe.
Yeah.
Well, that's a really good strategy, because it means that you both can get a better night's sleep.
Yes. Yeah, he does. My dad does as well now.
So perhaps is he a little bit less aware of what's happening now with your mum?
I know in the past you were shouting out in the night. I think
So
that's
he
what
said,
we
yes.
spoke about before, but he's not mentioned that actually.
Okay.
But then, having said that, I think he's quite deaf now, isn't he? So
he's
I'm
got
not sure he
hard of
would
hearing,
hear her
yeah.
in the
Okay.
other room.
Okay. Sometimes a telltale sign is what your bedclothes look like in the morning,
Yeah.
and if they're all over or off the side of the bed, it means that you may have had a bit of a more of an active night.
They still can be
They
a
still
bit,
can
bit
be.
all over the place, and I'm still having very strange dreams.
Okay.
Quite vivid dreams, quite unpleasant ones.
That you recall.
Yeah, but they don't make any sense at all. They're
Okay.
just rubbish, really, all over the place. No sense to them.
Does that distress you, worry you?
Yeah, when I wake up and think about it, it does a bit, yeah. It doesn't last too much, though.
Okay, and how often?
2-3 times a week, something like that.
Okay. Have you been up at night? Had any falls, for example?
Not recently, no. Not since I made those changes. I have in the past fallen out of bed more than
Yeah.
once.
Okay.
Yeah, she did quite a few times actually. But Dad helped out, didn't he? Because he came in and moved the bed up against the wall just to help, and I think
Yeah.
that helped.
It
Didn't
seems to have.
Okay, that's good.
Yeah.
Sometimes people feel it's useful to have a night light in the hallway or the landing, in case you do get up at night to use the toilet.
Yeah.
To just help to orientate you a little bit, and that can sometimes help with the disorientation.
Okay.
That might be quite useful, yeah.
Okay. I mean, it sounds like the strategies that you're using are working fairly well at the moment, and I would advise that these continue. Yeah.
In the video, we heard about one of the most significant sleep-related symptoms in Lewy body dementia, REM sleep behavior disorder. It is important to recognize that REM sleep behavior symptoms are just one of many sleep-related symptoms that Lewy body dementia patients may experience. Others can include intermittent wakening or insomnia, motor-related sleep disturbances, restless legs, periodic limb movements, and sleep apnea. Within the management toolkit, we provide advice and guidelines on the management of these different sleep-related symptoms. There are a number of general principle points that we can give with regard to our patients with Lewy body dementia in regard to their sleep. Firstly, consider good sleep hygiene, avoidance of stimulants, particularly in the late afternoon and evening, Avoid alcohol in the evening. Establish a regular pattern of sleep. Have comfortable bedding. Make sure that the room temperature is optimal. Restrict daytime naps if possible, and ensure that there is regular exercise. It is also important to review all medication and avoid any drugs that might affect sleep or alertness, or indeed interact with other medications. In regard to REM sleep behavior symptoms in Lewy body dementia, there are a number of non-pharmacological strategies which should be considered first line. Consider placing the bed or mattress on the floor, removing any potentially dangerous objects which might be in the room, or putting padding around sharp or firm objects. Bed partners may be required to sleep separately, although this conversation needs to be handled sensitively. It is important to consider and exclude potential mimics of REM sleep behavior symptoms, including obstructive sleep apnea. There is no clear evidence base for the treatment of REM sleep behavior symptoms in Lewy body dementia. However, our expert panel recommended a number of pharmacological agents. Low-dose clonazepam taken before bedtime can be effective. Be aware, though, of side effects, particularly increased risk of falls and worsening cognition. Melatonin is another treatment option. Despite the lack of evidence, it may be considered first-line treatment given its relatively benign side effect profile. It is also important to be aware that some of the medications that are given in Lewy body dementia may exacerbate the REM sleep behavior symptoms, for example, certain antidepressants.
How have you found your mobility over the past few weeks, Margaret?
Not great, actually. Things aren't the way they were.
Oh, I'm sorry to hear that.
Yeah. I'm just walking a lot more slowly.
Okay.
You're linking arms with me more, aren't you, when we walk down town?
I can't seem to lift my feet very high, if you know what I mean.
No, it's more like a shuffle. It's like she's shuffling along now.
All right. Okay. So how? Just to clarify, how long this has been going on for?
I don't know really. When did it start?
I'd say maybe it's over the last few weeks, really.
Yeah.
Okay.
Yeah.
Mm-hmm. Anything particularly set it off, or made it any worse?
Nothing I've noticed. No.
No, I did wonder though if it might have something to do with Mum's medication that she's on, if this is what's causing this.
Okay. So that was that donepezil medication that we gave you for your memory.
That's right.
Yeah.
Yes.
Okay.
I'm struggling more on stairs and any kind of steps.
Curbs outside. Yeah.
That's right. I do have a bit of arthritis in my knees, so I don't know which is what, if you know what I mean.
Have you had any falls?
No.
Good.
No.
Okay. And are you remaining pretty much independent at home as you had been, or are you requiring any help?
Yes, I'm still pretty independent, yeah.
Okay. I hope you don't mind me saying I had noticed the tremor in your right hand.
Yeah.
So tell me about that. When did that start?
Again, I think it must be weeks. If I pick up a mug of tea or something like that, I'm sometimes spilling it.
Okay.
But I can't really remember exactly when it started.
But other than having the odd spillage, you managing okay?
Yes.
In the kitchen at home?
Yes.
Cooking your...
Yes.
Okay.
Yes.
Okay.
I just have to take my time and think, try and think about things,
Yeah. I wonder then if it would be useful at this stage to have a more formal occupational therapy assessment to see if there's any adaptations that might help at home, obviously to prevent you burning yourself. Something simple like a travel mug can sometimes be useful. You know, if you're drinking a hot cup of tea and you have a tremor, it stops the spillage.
Oh, that might
that kind of thing. So we could organise that. Just need to bear in mind with what you said about this mobility problem occurring after the start of the medication, and I think we will need to monitor that because
Right, okay.
You know, it may be cause and effect.
Is there any other kind of treatment I could have if it's the medication?
Well, I think we'll have to balance up the benefits and the side effects of all the different treatments. So the medication, the donepezil medication that you think might have worsened your mobility is obviously good for the memory, concentration and other symptoms. But some patients with dementia with Lewy bodies do receive similar medication that we would give patients who have Parkinson's disease, levodopa therapy it's called. But usually we reserve that for people who are having difficulties, you know, managing their day-to-day function. So possibly slightly more than you're having at the moment. And we've just got to be careful because sometimes people with dementia with Lewy bodies can be less responsive to the treatment than you find in people who have Parkinson's disease. But it's certainly something, if your mobility deteriorates, it's certainly something that we could consider, sure.
Okay. Yeah.
Motor symptoms in Lewy body dementia include tremor, rigidity and bradykinesia, amongst other symptoms. They can have significant functional impacts on people living with Lewy body dementia, and this, coupled with other symptoms, can lead to the increased risk of falls as well as other increased morbidities. In our management guideline, we consider the management of motor symptoms in dementia with Lewy bodies and in Parkinson's disease dementia differently, given that in the majority of cases, people with Parkinson's disease dementia are already on anti-Parkinsonian treatment which needs rationalization. Whereas in the case of dementia with Lewy bodies, it is often the question of initiating anti-Parkinsonian treatment. In the subsequent slides, we will focus on the management of motor symptoms in dementia with Lewy bodies. There are a number of general principles to consider in the management of motor symptoms. Firstly, establish whether these motor symptoms are significant or not, whether they are impairing function and warrant treatment. Exclude other factors that might be a cause of worsening motor function. Be aware that Parkinsonian symptoms may be less treatment responsive in dementia with Lewy bodies compared to Parkinson's disease. Also, it is important to remember that pharmacological treatment of motor symptoms in dementia with Lewy bodies can worsen cognition as well as neuropsychiatric symptoms. Pharmacological management of motor symptoms in dementia with Lewy bodies is levodopa monotherapy. Use the minimal dose required for benefit. Remember that the doses are often lower than those needed in Parkinson's disease. Start low and go slow. Watch for side effects including psychosis, postural hypotension, sedation, as well as nausea and vomiting. Zonisamide can also be considered as an adjunct to levodopa, and it may have some motor benefits in Parkinson's disease as well as dementia with Lewy bodies. There is also a range of non-pharmacological approaches which should be considered. Physiotherapy, occupational therapy, vitamin D supplementation where appropriate, as well as speech and language referral for motor-related speech and swallowing problems.
So have you had any symptoms of dizziness, Margaret?
Yes, I have,
Mm-hmm.
yes.
Can you tell me about those?
I've been going on for a little while. I'm all right most of the time. But if I stand up, suddenly I can feel really lightheaded and unbalanced, if you understand me.
Okay, Have you fallen or fainted or had any blackouts at all because of these?
No, I haven't, no.
Good, okay.
And other times it just seems to be when I've been still for a while. Getting out of bed in the morning, it can happen then.
Okay.
Just sitting down for any length of time generally, yeah.
Some people notice it can be worse if you've had a big meal.
Yes, it does happen after I've eaten, yes.
Okay. If you've gone to the loo, if you've been particularly constipated, sometimes people feel a bit lightheaded afterwards. Is that something that you recognised? Yeah. Okay. It's very useful then if you are prone to constipation that's treated appropriately.
Okay.
Obviously reduces the risk.
Right, okay. We'll have to get something, I suppose. Yeah.
We'll have a look.
Yeah.
The other thing that I think has often been helpful for patients is to have a big drink of water the moment you wake up on a morning. So before you actually get up, if you have a bottle of water, 500 mils, for example, drink that, and really do promote rehydration throughout the whole of the day. That can help with the symptoms of dizziness, certainly.
Okay,
You could try that.
I'll try that. Yes, I will.
Yeah. I know me and my dad, we've been kind of trying to say for Mum to get up a bit more slowly.
Good.
When she's sat down.
That's a good strategy.
And you've been doing that, haven't you?
Yeah, I have, yeah.
I mean, the other thing that we can check is your blood pressure medication, because sometimes we find that might need ever so slightly altering, and we can do that via your GP.
Oh, we've done that, haven't we? We went a few weeks ago. Yeah, and they took her blood pressure and said it was quite low.
Okay, so they made some adjustments to your normal medication.
Yeah.
Okay, good. Well, it would be important to follow that up and make sure we check your blood pressure. Obviously, avoiding alcohol is sensible if you're feeling slightly lightheaded or dizzy.
No, I don't really drink. Not now.
You're not much of a drinker,
not
are you?
at all. No, I used to quite like a glass of wine. I just don't feel like it at all anymore.
Okay. What sounds like things are going in the right direction at the moment, but I think if you do start to feel very dizzy, and that leads to falls or any blackouts, then it certainly would be useful for us to refer you on to a specialist, to a falls and syncope service, to have some further assessment for that. But that's something, if we need that in the future, that we can look into that.
Yeah, that
certainly.
would be okay, wouldn't it?
Yeah, I suppose so. Yeah.
Autonomic symptoms are common in Lewy body dementia. They can have significant impacts on quality of life. The video focused on orthostatic hypotension, but it's important to be aware that there is a wide range of autonomic symptoms in Lewy body dementia. These can range from constipation, gastroparesis, swallowing difficulties, drooling, excessive sweating, and urinary symptoms. In the management guideline, we cover the management of all these different autonomic symptoms in Lewy body dementia. Looking at orthostatic hypotension specifically, there are a number of general principles. There are many things which can cause or exacerbate orthostatic hypotension in Lewy body dementia. These include medications, dehydration, cardiac disease, fever, and anemia. Orthostatic hypotension can occur at particular times, for example at meal times, when taking alcohol, in the early morning, during defecation or micturition, or indeed with physical activity. If there is significant dizziness, falls, or episodes of loss of consciousness, consider a referral to a falls or syncope service. There are a number of non-pharmacological approaches to the management of orthostatic hypotension in Lewy body dementia. Consider telling the patient to stand slowly. Raising the head of the bed for morning orthostatic hypotension may help. A slight increase in salt intake may help some, as well as the use of compression hosiery. Increased fluid intake, the usual advice is 2 litres a day, may be also considered for some individuals. In regard to pharmacological management, fludrocortisone and midodrine are potential agents. These need to be titrated slowly, and there needs to be monitoring of electrolytes in the case of fludrocortisone, as well as hepatic and renal function in the case of midodrine. It's important to note that these medications may cause severe supine hypertension and are best initiated and monitored by a specialist.
Have you had any difficulty passing urine, Bill?
Not really passing it, no, but I need to, I feel I need to go quite often, much more often.
Okay. Is that during the day, at night?
Well, at night I maybe go 3 or 4 times, but it's during the day. I go every half an hour sometimes.
Oh, goodness me. And have there been any accidents as a consequence?
Yeah.
That's difficult.
It's really embarrassing because
It is.
I'm having to change. I wear pads, and it's not something I like. But
Yeah.
yeah, sometimes I wet the bed.
Something you have found really embarrassing, isn't it? He didn't really tell me about it either, did he? But I happened to come round and found he'd been washing the sheets, and that's when I sort of found out what a problem it had been for him.
And this has been going on for how long?
A few years now.
Yeah, I would say so.
And I can sense it's a huge problem.
Yes. I mean, that's my main problem, I think.
Your main problem. Have you had any investigations performed by your GP to look into any of this, to exclude any other treatable conditions?
Yes.
Mm-hmm.
Yeah. They couldn't really find anything else.
So everything was reported as normal?
Yeah.
Yeah, the GP, because I went along as well, he'd said to check for things like problems with the prostate. But he
Okay.
just assured us that there was
So
nothing.
your prostate gland's okay?
Yeah.
Was there anything else that they found?
They did find something, wasn't there?
They thought you were a bit constipated at the
Yeah.
time.
And we know that that's common, isn't it? It's a common symptom in Parkinson's disease. And if we could get that treated, you might find a little bit of improvement in your frequency. You know, the need to go to the toilet so often. Have you found any improvement?
Maybe, yeah.
Okay.
A bit.
Sometimes cutting out caffeine can also help.
Mm-hmm.
It's a small measure, but that can help. Now, correct me if I'm wrong, but were you not on some treatment for problems with your bladder?
Yes.
And was that discontinued?
Yes.
Mm-hmm.
I stopped it.
Was that for a particular reason?
I stopped it because
You'd said, sorry to speak over you, you'd said that you felt your memory was a bit worse when you were taking
Yeah.
that medication.
yeah.
So that's why it was stopped again.
Okay. And did you find that treatment helpful when you were taking it?
Yes.
You did. Has the rivastigmine tablet that we prescribed made the waterworks any worse?
I think it might have done a bit, yes.
Yeah.
Okay. So we're in a bit of a dilemma, aren't we? We've had some treatment that was really very good for your bladder. That was stopped because of your memory problems. We've given you additional treatment for the memory problems, and again, that's made you go to the toilet more frequently.
Yeah.
So we're in a real catch-22 here.
It was like a vicious circle, wasn't it, at the time?
Yeah, and that's not uncommon. And I think what we need to now do is think about what our priorities are for you. What's worse? And it sounds to me that the waterworks are quite problematic at the moment. Having said that, however, there are other things that we can do. I think it will be really useful to get an incontinence assessment, because there are some other things that can be put in place that you might find helpful, particularly to help you maintain the continence at night, so you're not having to change the sheets every day. So I think if we do that in the first instance, and then we maybe need to think about the tablets and which ones we're going to prioritise.
Yeah, okay.
Okay.
That would be helpful, wouldn't it?
Yeah.
Stop
Yeah.
having to wash the sheets.
Yeah.
Good.
That would be really good.
Good.
We will briefly touch upon the management of urinary symptoms in Lewy body dementia. Non-pharmacological management of urinary symptoms in Lewy body dementia should be first line. Consider regular prompted voiding. The use of incontinence pads may be helpful in some cases. For more complex issues, which are refractory, consider referral to an incontinence nurse or urology. Pharmacologically, it's important to consider either reducing or avoiding diuretics if possible. Be aware that cholinesterase inhibitors can precipitate urgency and urge incontinence in Lewy body dementia. It is important to avoid those bladder agents which have a strong anticholinergic effect. Intravesical botulinum toxin may have a positive effect in those intolerant of anticholinergics and with detrusor overactivity. Meribagron is another agent which might be considered as an alternative to anticholinergics for bladder overactivity. Note that it's important that the underlying causes of urinary incontinence are properly investigated first before considering any pharmacological treatment.
I hope you found those exemplars helpful. It is important though to remember they are just that. Each person is of course an individual, and particularly for Lewy body dementia needs an individualised approach to their management. Key benefits that were identified by clinicians who used it during our piloting are that it was seen as a valuable, practical toolkit, evidence-based, with easy layout and suitable for use in routine practice. Clinicians reported high confidence in the trustworthiness of the toolkit because of the robust, evidence-based way it was developed. And they reported increased confidence in their ability to manage Lewy body dementia by using it. We want the toolkit to be used. It's freely available to download from the Diamond Lewy website or typing Diamond Lewy into your search engine. We would emphasise that it's a toolkit specifically for Lewy body dementia, and it's designed to be used alongside management for dementia that would apply to any dementia type. For example, as contained in NICE Dementia Guideline. During our piloting, people found it helpful to print out the individual sheets and laminate them and have them available in the clinic, as well as having the toolkit available as a PDF version electronically. We hope that you will use it in clinic when seeing patients. We also hope that it will be useful as a teaching aid and also in case discussions of Lewy body dementia when thinking about alternative management approaches. We hope you find the toolkit useful, and thank you for watching.